Thousands of accidents like the one you're about to see happen every day. In North America alone, disabling injury strikes over 9 million people yearly. More than 50,000 of these accident victims suffer one of the most tragic consequences imaginable, spinal cord injury. The care these patients receive in the field can literally make the difference between life and death. An awareness of proper spinal immobilization techniques and the treatment decisions made on scene can greatly impact patient outcome.
Traffic collision, looks like 2 victims. Send me a second ambulance and update the status of rescue 1. Okay, ma'am, we're here to help you.
No, don't help me.
Okay, Cap, I got a normal ABCs. The child's unconscious, 40 pounds, 10-year-old.
Does he talk to you or move
No,
at all since you've
no,
been here?
no, unconscious. His breathing is normal.
Okay, looks like he's going to need a pediatric seat cover.
Yeah, breathing well, doing okay.
Good. Come right up under her upper neck and under her chin. Hold your head still, dear. Now hold your head still. Here, we're going to take care of you. Don't worry about him. Tell me what day it is, Tina. Well, I'm going to readjust for you.
Breathe. Okay, let's start over. Easy, easy.
Make a level single motion.
On 3. 1, 2, 3. That's good.
What do you guys need? Okay, this will be our number 1 patient, children number 2. Just assist the firefighters in getting out of that vehicle, will you? All right, don't forget it. Yeah, can we get back? Okay, that's it. So we can sneak it in there. Tina, what day is it? Yeah, I'll be back in a minute. We're just going to load the kit. Yeah, I'm going to take your lid. Okay. That's okay. Look at the head.
How about the legs? You with us, Tina?
Talk to me, Tina.
Yeah, I've got her shoulders. Get her legs. Good, good.
Tina, where are you right now?
All the way down.
Keep an eye on his airway and get her 2 on him as soon as you can.
I'm ready with the ambulance, officer.
Okay, go ahead. Ready? All right, we set, we're straight, and we'll go ahead and set the headbed. Yeah, hold that still. Okay, 1, 2, 3. Papa, why don't you get a suction unit handy and go ahead and transport with it. We'll pick you up at the hospital.
Of the more than 50,000 accident victims that have suffered spinal cord injury, sadly, it has been estimated that 3 to 25% of these patients receive injury to the cord itself during the pre-hospital and emergency department phases of their care because of improper immobilization and handling techniques. Initial and continuing education on proper pre-hospital and in-hospital spinal care can significantly reduce the number and impact of these injuries. As quality pre-hospital care systems have been developed, the percentage of patients with complete paralysis arriving at spinal cord injury centers has decreased by more than a third. New drug therapies offer increased hope for recovery, but how skillfully patients are cared for on the scene remains the critical factor in lessening secondary cord injuries. You can make the difference. In the next few minutes, the call you have just seen will be reviewed, emphasizing the principles of spinal care, proper use of the Stifneck extrication collar, and the headbed cervical immobilization device. As the rescuers approach, scene assessment begins immediately. While determining that the scene presents no unnecessary risks for emergency personnel, rescuers can generally tell whether the call is medically or traumatically related. The rescuers then determine how many patients are involved and if there is a need for more medical assistance. The preliminary assessment of the injury kinematics will often alert rescuers to the potential for spinal injury. Any severe impact or deceleration represents a mechanism of injury that demands patients receive complete spinal immobilization. In this case, the spidered windshield clearly indicates the need for spinal immobilization, despite the generally stable appearance of the woman. Initial patient assessment focuses on the ABCs: airway patency, presence and quality of respirations, and circulatory status. On a trauma call, patients are assessed with overriding thoughts of the need for rapid transport and the possibility of spinal injury. In most cases, spinal immobilization begins by positioning and maintaining the head in a neutral or eyes-forward position without traction. The neutral position is preferred because, as can be seen in this computer-reconstructed CT image, the maximum space for the cord within the spinal canal is available when the patient is in neutral alignment. Additionally, it is in this position that a spinal fracture is generally more stable. This is important because any compression of the cord can cause permanent neurological damage. In situations where stenosis, swelling of the cord, or bone fragments extend into the canal, any further reduction in the dimension of the canal can be the cause of an injury that will lead to permanent paralysis or death. Flexion or extension can significantly limit the size of the canal. Hyperextension, for example, has been shown to reduce the spinal canal by up to 30%. For this reason, it is important that the patient's head and neck are maintained in the neutral position during immobilization. Established protocols call for the rescuer to return the patient's head to neutral unless contraindicated. Contraindications include if movement causes neck spasm, increased pain, commencement or increase of a neurological deficit, airway or breathing complications. Check with your local EMS authority for approved protocol. Neutral positioning must be determined by the rescuers. As a guideline, neutral position is determined by placing the patient's head with their gaze straight forward, perpendicular to the spine. On most people, estimate neutral by visualizing a line parallel with their spine and a second line extending straight forward from their eyes. Extension produces an angle greater than 90 degrees, while flexion produces a lesser angle, possibly causing increased pressure on the cord. After the initial assessment and immediate manual stabilization of the head and neck, the next step in the immobilization of this patient is the application of an extrication collar. The Stifneck extrication collar has evolved and improved over time. Assembly, sizing, and proper application, however, remain unchanged. Proper assembly, sizing, and application as detailed in the instruction sheet are essential if Stifneck is to provide optimum patient care. To assemble the Stifneck, simply push the black fastener firmly into the hole. Preform the collar by flexing it sharply inward in the area of the hook Velcro. This step simplifies application by conforming the collar to the patient's neck. Stifneck collars come in 4 adult and 2 pediatric sizes. Using the correct size Stifneck is essential for maintaining neutral alignment and ensuring proper immobilization. Use this easy sizing method. With the patient manually maintained in neutral, Measure the height between the trapezius muscle at the base of the neck and the bottom of the chin, as these are the support points of the collar. This height is referred to as the key dimension. Use your fingers to measure this distance. As this graphic shows, because the chin piece is aligned with the sizing post on the collar, you can select the correct size collar by measuring from the sizing post to the lower edge of the rigid plastic. This collar is too tall. For this patient, the regular size is the correct collar. Practice this once or twice, and you will soon know how many of your fingers measure out to each size of stiff neck. Proper positioning of the chin piece is the most important part of putting on a stiff neck. Application is simple if you slide the preformed stiff neck up the chest wall until the chin is well supported. The chin should basically come to the end of the chin piece. If the patient's chin does not at least cover the central fastener on the chin piece, stop and start again by sliding the collar up the chest wall. When done correctly, the chin should basically come to the end of the chin piece. Application is completed by positioning the back panel behind the neck and tightening the loop Velcro. While doing this, hold the collar firmly against the chest wall by grasping the collar in the corner of the trachea hole. This prevents any possibility of rotation during tightening of the collar. When properly sized and applied, the neutral position determined by the rescuers and manually maintained throughout will not be altered. Again, check to ensure that the chin remains properly supported. Readjust if necessary. Application to the supine patient is similar. Slide the back panel behind the patient's neck until the looped Velcro can be grasped, but no further. As soon as the looped Velcro is visible, turn your attention to correct chin piece placement. Use both hands to slide the collar up the chest wall so that it supports the chin. Again, when properly applied, the patient's chin will come to the end of the chin piece. Sizing and application is the same in adults and children. The baby no-neck, the smallest stiff neck, generally fits patients aged 12 months to 3 or 4 years of age. The pediatric generally fits children aged 3 to 8. However, in some cases, geriatric patients may be fitted well with the pediatric collar. Larger children may also be properly fitted by the adult size, no-neck or short collar. The goal of pre-hospital spinal care is the prompt delivery of a patient to an appropriate medical facility without causing secondary damage or aggravating the initial injury. Transfer to a rigid spine board is a key step in this process. Several methods exist. For the woman involved in this accident, rescuers have chosen rapid extrication because her deteriorating condition demands prompt transport. In other situations, should time allow, use of an extrication device may be appropriate. The boy, who presents in the supine position, is being moved by the log roll maneuver. A minimum of 3 people are necessary to perform the log roll. However, an additional person responsible for positioning the board is preferred. Typically, the rescuer who is maintaining neutral alignment will coordinate and direct the team. The goal is to move the patient onto the board with as little movement as possible. To accomplish this, slowly and evenly roll the patient onto their side. Position the spine board as far as possible under the patient and raise it to a 30 to 45 degree angle. At the direction of the lead person, roll the patient onto the board and lower the board back to the ground. With care, cervical spine motion can be all but eliminated. However, a study has shown that lumbar motion may still be present. With enough personnel, an alternative to the log roll that may be preferred is the flat lift. The flat lift is best performed when adequate rescuers are available to completely support the patient. After the patient has been positioned on a spine board, the fit of the collar should be rechecked. While any number of strapping techniques can be effective, On smaller patients, consider the use of padding to fill any space between the patient and the straps. Whatever technique is used to position the patient on the spine board, once there, they must be secured from head to toe. Specialized equipment has been developed to aid in immobilizing the head on the board. California Medical Products Headbed CID, introduced in 1989 and redesigned in 1991, attaches to a standard spine board and provides extremely effective immobilization of the head without limiting access to the patient. The headbed is quick and easy to use and can be positioned on the spine board after the patient. The open design complements the new Stifneck's extra-large trachea opening and permits ongoing assessment of the patient's head for cerebral spinal fluid, blood, or direct trauma. In addition to being inexpensive, lightweight, and easily stored, Headbed significantly improves patient comfort and is completely radiolucent, so it can stay with the patient until they have been radiographically cleared or sent to surgery. To use the redesigned headbed, open the plastic package and detach either side of the Velcro strap, leaving the other side attached. Position the headbed beneath the patient's head with the graphic ears beneath the patient's ears. With the patient held in neutral alignment, assess the gap between the back of the patient's head and the board. To make filling this gap and preventing extension easy, California Medical Products makes the Pad Pack. While holding the headbed with one hand, slide the appropriate number of 3/4-inch pads into place. Now, slowly lift up the side panels, allowing the rescuer maintaining alignment to carefully reposition her fingers so that the panels are held in contact with the patient's head just above the ears. Position the Velcro strap across the patient's head just above the eyebrows. Tighten and secure it to the opposite side panel. With the headbed properly positioned on the patient, attach it to the board by simultaneously pulling the red plastic tabs. This exposes an aggressive, water-resistant adhesive to the board. Press down firmly. To complete the application, remove the folded tape piece and peel back enough of the liner so that the tape can be firmly attached to one side of the board. Peel back the liner and with the tape pulled tight, position it across the Velcro strap. Tape directly over the Velcro strap and the eyebrows. Finish by securing the tape to the other side of the board. Peeling off the liner as you go decreases the chances of the tape sticking to itself. The patient's head is now immobilized and manual immobilization can be released. No matter what type of product is being used, proper immobilization will not be achieved unless the device is used correctly. The following information is intended to help users of the Stifneck Extrication collar and the Headbed CID to provide the highest level of patient care. Remember that a high index of suspicion is most important when caring for a trauma patient. Even in a patient with no visible trauma indicators, neurological deficits, or complaints of head or neck pain, mechanism of injury can dictate the need to immobilize. In one study, 17% of patients with vertebral fractures were found walking at the scene of their accidents. Before sizing the patient, make sure that their cervical spine is in neutral alignment. Sizing a patient who is extended will lead to the selection of too tall of a collar, while sizing in flexion leads to the selection of too short of a collar. Despite the fact that preforming is quick and easy, it is often forgotten or simply not done. Preforming causes the collar to conform to the shape of the patient's neck, which reduces the possibility of premature Velcro attachment. An improperly applied collar provides little, if any, protection for the patient. It is the responsibility of EMS personnel to ensure correct sizing and application which will prevent this. Assess the key dimension, select the correct stiff neck size, and slide the collar up the chest wall so that the chin is well supported. Sizing is critical to maintenance of neutral position. Too tall a collar can cause hyperextension and possible injury. Too short a collar will provide only a limited amount of immobilization and can act as a constrictive band. Although a no-neck size collar can be easily applied to almost everyone, using it on all patients is a shortcut that should be avoided. Although they represent only a small percentage of the population, some patients require the tall-size stiff-neck collar for proper immobilization. Optimal patient care calls for rescuers to have available the 4 adult and 2 child sizes. Stiff-neck's circumferential adjustability allows it to fit essentially all patients, regardless of neck circumference. The patient on the left has a 14-inch neck, while the patient on the right has a 19-inch neck. In fact, neck circumference is not related to proper size selection. Both these patients have 15-inch necks, however they require different sizes of stiff neck. Stiff neck's enlarged tracheal opening provides improved access for ongoing assessment of the carotid pulse, monitoring for possible jugular vein distension, or checking for tracheal deviation. For proper support, loosen or cut away clothing so stiff neck makes direct contact with the patient. In extreme cold, it may be appropriate to size and apply stiff neck over the patient's clothes. Check for the approved protocol in your area. An extrication collar is an important component of the total immobilization system, as it can be applied before movement of the patient. Despite the fact that one study showed a properly applied stiff neck collar to provide 80% of the immobilization provided by a shortboard or KED, stiff neck should never be used alone, and even after it has been applied, manual immobilization should be maintained. While the headbed is constructed of a durable corrugated board, it is really the tape that provides the immobilization. Flexion and lateral motion are essentially eliminated. The modest amount of rotation that is possible is due to the motion of the skin over the skull. The headbed is built with a specially treated water-resistant corrugated board. While it should not be completely immersed in water, usage in extremely wet environments has shown that its ability to provide effective immobilization is undiminished. One note of caution is, however, warranted. In extremely cold conditions, the adhesive may lose some of its tackiness. For this reason, care should be taken to press the adhesive panels down firmly. If the board is wet, or if there is any chance that the tape is not secure, use an additional piece of tape. Tape over the first piece and completely encircle the board. Now let's review the important steps in managing a trauma call requiring spinal immobilization. While approaching, assess the scene for unsafe conditions. Determine the type of incident, number of patients, and the possible need for additional support. Initial patient assessment focuses on airway, breathing, and circulation. Throughout, a high index of suspicion regarding the possibility of a spinal injury must be maintained. Determine transport priorities. Define and maintain neutral position. Measure collar using the key dimension. Position the chin piece by sliding the collar up the chest wall. Transfer the patient to a spine board and immobilize the patient completely. Pad as needed to maintain alignment and for comfort. While maintaining manual head immobilization, completely secure the body and the head. During transport, monitor the immobilized patient for possible vomiting and keep suction ready. As pre-hospital equipment and training have evolved, patient care has improved. Today, the percentage of patients arriving at spine injury centers with a chance for recovery has dramatically increased. With these guidelines in mind, you can have a significant impact on patient outcome. You can make a difference.